Hey, good morning, everyone, and welcome to UroNurse, your go-to place to learn more about urology. So, all you healthcare workers, this is the place to come. And if you're joining us live, welcome to the show. We come to you every Saturday at 9 a.m. Central Time. Never miss a beat. This is, I think, 114th episode. Yep. And we're on all the things that you see surrounding me here. So be sure to check us out. Otherwise, we're always available on demand. Go to our website. Oops, there we go. At euronurse.com. Best place to catch all of our past episodes. Also, the very best place to learn more about the show. Visit our sponsors, get more information. So check us out, euronurse.com. And like I said, you want to watch the past episodes, we have 113, soon to be 114 episodes up there. Check them out. Be sure to get a good look at them all. And if you like to listen to us in your car and you don't have the time to watch the show, no problemo. Go to our UroNurse Plus area. It'll bring you over to our audio podcast. You can pick out your favorite podcasting format and subscribe, and you'll get that into your mailbox almost every day shortly. Well, you'll not get it every day, but you'll get it shortly after the episode airs because I have to load it up to that platform. So about an hour later, it should be up there. So, hey, listen in your car. We've got a really good show for you this week. We're coming to you with another one of our earn some credits called Skin Antisepsis in the Prevention of Surgical Site Infections. So we're going to be doing one of those today. And I'm the only one here today, so I don't have any experts to bring in. Of course, I think on these CE ones that we tend to have the audience off. I know for a fact, Lori Atkinson's birthday's today. Happy birthday, Lori. And Andrea's on vacation, so she's not going to be visiting us for a little while. So I'll be manning everything here. So you're going to have to kind of bear with me as I try to zoom through some of the comments that you guys have sent. But I did have an announcement I wanted to make after the SUNA conference that I was at last week. I ended up winning 2 awards, and I'm thanking you guys for these awards because I'm sure that's why I won them. So this is the Ardith Hale Award from SUNA, and it's a award given for leadership. So that's not bad. But the biggie, and it's so heavy I can hardly lift it up, is this one. So this is the SUNA. I don't know if you can read it here. I'll put it in front of my shirt. There we go. SUNA's President's Trophy. And this is for excellence in urology, contributions to urologic nursing. And I really, really was happy to receive that one because I can tell you that this show is, I'm sure, what helped to drive that. But I've been doing stuff in urologic nursing my whole career, and now I got recognized for it. So, hey, I hope everybody likes that. I was really happy. I'm going to take a quick look at the comments, and then we'll get going on our show. Let's see what we got coming in here. We have morning from Amy, Glenda Wilkinson. Good morning. Neil Smith. Good morning. Susie Swain says, good morning. Tabo. Good morning from Marin County, California. And Diane Clowers, morning from Seattle. Hey, good morning, everyone. Welcome to the show. I did get to meet a lot of you guys live. Whoops, I got to get my last comment here. There we go. I did get to meet a lot of you guys live at the show at the SUNA conference, and it was really kind of neat to get to see the names that I see flashing across the screen and then have the real people show up and say hi. So that was really fun. Okay, I got another one that just came in here from Tavo, and congratulations on winning the award. Well deserved. And thanks for everybody who on my LinkedIn page, I posted an actual picture of me holding the trophies, and all the thanks for all the nice comments I got from everybody telling me well deserved. Again, I think without you guys, this never would have happened. So I'm, like I said, I couldn't be more pleased than to win that. That's really means a lot to me. So, and putting on this every week is really important to me too. So we're going to get going. This is a video. I'm going to run that. And then afterwards, I will come back on. It's a shorter show. It's only about, I think about 15, 20 minutes. It's good for a half hour worth of credit though, which isn't bad. And then I'll come back on. Maybe we can have a little discussion going with all the viewers. Any questions you have? I got a few things. I presented actually a little bit about skin prep during the SUNA conference. So I'm going to go through a few slides on that. And otherwise, we'll just hang out a little bit and let's get going with the show.
Hello, my name is Dr. Laurel Robinson. And I am a nurse practitioner with the Kentucky Infection Prevention Training Center and Norton Infectious Diseases Institute. Today, we'll talk about skin antisepsis in the prevention of surgical site infections. Funding for this presentation is provided by the Kentucky Department for Public Health. Content includes discussion of unlabeled use of products. The presenter has no financial interests or other relationships with the manufacturers of products. No commercial support was provided for this educational activity. So our objectives today will be to discuss the significance of surgical site infections, in particular, the impact of SSIs on patient outcomes and healthcare costs and hospital resources. We'll discuss the role of skin antisepsis in the surgical setting for the prevention of SSIs. We will define current recommendations by the AORN, which is the Association of Perioperative Registered Nurses, for surgical skin prep selection and application. And we'll define aseptic technique and identify breaks in sterility that can lead to SSIs. So surgical site infections, again, also known as SSIs, by definition, a surgical site infection is an infection that occurs after surgery in the part of the body where the surgery took place. Surgical site infections can sometimes be superficial infections involving the skin only. Other surgical site infections are more serious and can involve tissues under the skin, organs, or implanted material. Some factors such as age, gender, and comorbidities that predispose one to a higher likelihood of SSIs cannot be controlled. However, other factors such as skin preparation, using correct aseptic technique, are factors that we can control. SSIs are associated with prolonged duration of hospitalization, readmissions, reinterventions, permanent disability, or even death. There is an increasing demand for evidence-based interventions for the prevention of SSIs. Financial costs of treating SSIs are increasing. Also, there are increasingly complex surgical patients and procedures with technology advancements. It has been estimated that approximately half of SSIs are preventable by application of evidence-based strategies. Aseptic technique refers to the practices performed immediately before and during a clinical procedure to reduce postoperative infection. These include patient skin prep, hand washing, surgical scrub, using barrier protection for the patient, otherwise known as draping, and for the surgical team, maintaining the surgical field, using safe operative technique, and maintaining a safe and sterile environment in the surgical arena. Preoperative skin antisepsis occurs before surgery, and the goal of preoperative patient skin antisepsis is to reduce the burden of soil and transient microorganisms at the surgical site. This will help to reduce the patient's risk of developing an SSI. Effective skin antiseptics rapidly and persistently remove transient microorganisms, and they reduce the resident microorganisms to subpathogenic levels with minimal skin and tissue irritation. Preoperative bathing occurs the evening before or the morning of surgery, and the patient should bathe at least once with soap or an antiseptic to reduce that microbial flora on their skin. Also, please note that it is important to advise patients not to shave the day before or the day of surgery. If hair needs to be removed from that surgical site, the surgeon may choose to do so with clippers prior to the procedure. Not all germs can ever be eliminated, especially with a preoperative bath. So additional skin preparation occurs in the operating room prior to the procedure starting. So PrEP selection is a complex process based on knowledge of current research, clinical guidelines, and information provided by PrEP manufacturers, as well as feedback from frontline staff about how the products are used in practice. One of the more significant updates in the AORN guideline is the recommended use of alcohol-based antiseptics unless it is contraindicated. Alcohol has a broad spectrum of effective bactericidal activity, but it lacks persistence. Combining alcohol with another agent, such as chlorhexidine, also known as CHG, or povidone iodine, provides a rapid, persistent, and cumulative effect, notes the guideline. AORN recommends selecting an alcohol-based prepping agent based on the patient assessment and the anatomical location of the surgical site. There are contraindications for the use of alcohol-based skin preps. For example, alcohol-based preps should not be used on the mucosa or eyes, and studies have found that iodine-based non-alcoholic products are safest for use in the ear when applied with caution. There's also an inherent fire risk anytime you use an alcohol-based solution. You need to allow that prep to dry according to the manufacturer's directions. An example is typically 3 minutes for bare skin and up to an hour if prepped over patient's hair. Here are some examples on the screen that show a few alternatives to alcohol-based skin antiseptic solutions. Povidone iodine is one that is commonly used, or betadine. Also, solution forms of CHG with little to no alcohol content are used to prep for certain procedures. Surgical skin preparation with a CHG prep stick. First, you'll want to perform hand hygiene and then prepare the area for donning your sterile gloves on a stand or table above waist level. Open the sterile glove packaging carefully. Ensure that it doesn't flap back over the gloves. And you will want to make sure that you do this before putting on the sterile gloves, opening the prep solution, especially. It is not necessary to wear a sterile gown unless this is required by your facility. Also, sterile gloves can be optional if you are sure that you can avoid contact with the gloved hand, antiseptic, and patient skin. In that case, you can use clean gloves instead of sterile. You want to be careful to not contaminate your gloves when reaching in to get the prep stick. The internal portion of the packaging is sterile. If there is a cotton applicator in the package or a Q-tip, remove that as well. You may need this for an abdominal prep. Hold the applicator with the sponge down. Do not touch the sponge. Pinch the wings only once to activate the ampule and release the antiseptic. Pre-clean umbilicus, removing any debris with the cotton applicator soaked in the prep solution. When applying the solution, you'll want to partially load into the sponge by gently pressing the applicator against the treatment area. That will evenly distribute the solution throughout the sponge. Once the solution is visible on the skin, completely wet the treatment area with the antiseptic using gentle back and forth strokes, progressing from the incision site to the periphery of the surgical field. For dry sites, such as an abdomen or an arm, you'll want to use gentle, repeated back and forth strokes for 30 seconds. For moist sites, for example, inguinal folds or the axilla, you want to use gentle, repeated back and forth strokes for 2 minutes. After the patient is prepped, the prep solution must dry the allotted time. This ensures that we have the maximum antimicrobial effect and that the drapes are able to stick to the patient, and that we have reduced the fire risk as much as possible. For alcohol-based CHG preps, the dry time is normally 3 minutes for hairless skin, or up to an hour if prepped within patient's hair. Follow the manufacturer's instructions for use or your facility guidelines. After the dry time, the patient is then draped by the sterile surgical team with sterile drapes to prepare for the surgical incision. We will now watch a short video skit of a surgical prep being done with several noteworthy errors. Try to take a note of the errors you see, and we will then discuss these after the video. Now that we have viewed the video, I would like you to recall some scenes that show examples of improper sterile or aseptic technique when performing a skin prep. Number one, no hand hygiene was performed beforehand. Also, the setting up of the sterile field was done on the patient's lap. The sterile glove packaging closed over the sterile gloves before she was able to put them on. Do you see any other breaks in sterility? What's wrong here? Opening that prep packaging after donning sterile gloves is a break in sterility that could lead to an SSI. The outside of the packaging is not sterile, only the inside. Preparing the sterile field and opening sterile items ahead of time is ideal in order to maintain that sterility. In this particular situation, we're looking at a prep applicator that is way too small for the adult-sized patient's abdomen. Using the correct amount of surgical prep solution ensures coverage of the surgical site and optimizes the chances of not developing an SSI. See the manufacturer's guidelines for the recommended size prep applicator or prep amount for the surface area of skin needing to be covered. There is also no cotton tip applicator noted in this particular frame, and you would want to have that because for an abdominal prep, you'll want to clean the umbilicus with the cotton tipped applicator. Where is the break in sterility? The prep sponge has come in contact with the non-sterile patient blanket, so it's now considered contaminated. Being sure to cover all areas during the prep is extremely important. Inadequate coverage with the CHG prep solution can lead to surgical site infections. CHG prep sticks come in different sizes depending on the surface area to be covered. Follow the manufacturer's directions to make sure that all exposed skin in the operative site is covered with the antisepsis prep solution and that the proper dry time has occurred for the maximum antisepsis protection. Here we have a guideline from AORN that gives the prep applicator size for the corresponding prep areas that need to be covered. So to recap, SSIs can lead to increased length of postoperative hospital stays, drastically escalated expense, higher rates of hospital readmission, and jeopardized health outcomes. Skin antisepsis is a critical component of SSI prevention. The primary source of organisms contributing to infection following surgery is the bacteria on the patient's skin. The AORN recommends the use of chlorhexidine gluconate, CHG, with alcohol as the preferred antiseptic agent for preoperative skin preparation. CHG has been shown to be more effective than other antiseptic agents in reducing the incidence of SSIs. An aseptic technique refers to all the practices performed immediately before and during a clinical procedure to reduce SSIs. Maintaining sterility during the preoperative skin prep is an important part of the process to reduce SSIs. Thank you for attending this training.
Oh, that was pretty interesting. I kind of like the part where they show you how they're doing things wrong. Now, I mean, I really got a kick out of when they put the gloves on the patient, to open up the package of gloves on the patient. So that was kind of neat. But let me know what you thought of it. By the way, I'm going to discuss a little bit of, since we got some time. I'll take questions if you have them. Go ahead, put those through. If anybody wants to join the show and make some comments live, just go ahead and put that in the comments section. I can actually bring you onto the screen. So nobody's ever taken me up on that, but hey, maybe today will be the day. Otherwise, we can have a real good discussion through the comments bar. Tabo, you were the only one that did chime in on with some of those things. No hand hygiene. Definitely didn't wash their hands ahead of time. And she noticed how they opened the package with the applicator with the sterile gloves. So it's kind of neat. There was a few things they did wrong I didn't catch. Like they actually touched the blanket or whatever, the sheet with the applicator, and that kind of compromised it. But I'm going to go ahead and bring up my slides here so we can add to this discussion. There we go. So at the recent SUDA meeting, I was doing a similar talk with talking about prepping for vasectomies and prepping for cystoscopy. And what do you guys typically use for vasectomies? You can throw that into the comments. I'm going to just talk a little bit about our thoughts on it. And again, why it's important. I think they stress this infection prevention is key. You also want to make sure you're providing for good patient comfort so that they're comfortable during the procedure. And, of course, if you can prevent an infection, your success is going to be way up. Nobody wants to have a post-op infection. So all these things that we do ahead of time are very important. Now, I'm going to talk, because I decided to do a talk on vasectomies. I wanted something they didn't cover in this one. And I'm going to put this question out to you guys. Hair removal prior to a vasectomy. What are you guys doing? Do you have do you shave the area? Do you not shave the area? Do you have the patient shave the area? So I'm going to just give it a few minutes here to let you guys put some answers into what you would do. And I'm going to throw some of these things that have come up here. Glenda Wilkins said, "Hey, Glenda, hi. It would have been helpful to have helpful for non-OR nurses to see the video of correct prep. Would have been helpful for probably non-OR nurses to see the video of correct prep." And Susie agrees with Glenda. Good. So I know there's a delay from when I talk and when I start seeing the comments come up. So I know that I've got to deal with that a little bit. But anyway, put it in the comments. Do you guys, for vasectomies, the prep for vasectomies, are you cutting hair? Not? And let's see, we got some stuff coming up here. Susie Swain, have patient shave area day before. Okay, good. Anybody else going to throw a comment in there? All righty. I should have the Jeopardy music. Do, 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 do. Okay. I know early in the morning, people haven't had their coffee yet. Okay. Tabo, we use CHG for vasectomies. Sometimes the providers have patients shave. So it is sometimes. I agree with that. That's a good comment. Thanks, Tabo. And let me see. I'm gonna get my thing up here. So there was a couple of studies, interestingly, that were done about shaving prior to procedures, and the conclusion was that shaving does not decrease the risk of infection. And as a matter of fact, and there was the Cochrane database and the Jones Briggs Institute, two big studies that were done that looked at this, and there is some concern that if you, especially like shaving the night before, that type of thing, that the little micro nicks that you can put in the skin can become infected. And I've seen that. I don't know if anybody else has seen that. The having patients shave the night before, having them come in and they've got, like the little pimples forming on the skin because of those micro nicks. So it's really probably best recommendation is to shave the area right before and not to have them do it ahead of time. Uh, Past office experience were to do a shave. So thanks, Glenda, for that comment. And the one thing I did comment on is, all men are not created equal. So sometimes, for a vasectomy, if you got a really hairy scrotum, you may have to shave it regardless because sometimes the hair can fall into the wound. And if it falls into the wound, well, then it can be a source of causing an infection or at least an inflammation. So even though it's scrubbed down with a disinfectant, it can cause an issue. So typically, the way we do it, at least, is I know the area that the docs want shaved is just a small part of the scrotum that you have right below the penis. So we don't do a total shave because of the risk of causing skin irritation and infection. Just we shave the area where the incision is going to be made. Now, most of my docs are doing a single incision vasectomy. They pull both vases through the same area, so it's much less to shave. Some guys still do the two incisions, so you may have to shave more of an area. And again, if it's not a very hairy scrotum to start with, you may not have to shave anything. And Glenda Wilkinson said a bad shave can cause skin infection. Absolutely. So, Susie's right. Providers want patients to shave so hair doesn't get stuck in the sutures, and absolutely, and that kind of goes to my first comment about the amount of hair that you have there. So sometimes you can't prevent it. I can tell you that I can't even count how many scrotums for surgery. When I was back in the day when I was an orderly, I was on the floor and somebody was having it done in the hospital. I don't know why, but the prep order I got was to shave him from the umbilicus to his knees. I mean, that was a lot of hair removal. This was a really hairy guy, and I wasn't all that good at it. So I learned my lesson. All right, let's continue on. So anybody who uses the CHG sticks out there for vasectomy preps, let me know in the comments if you do, because I'm kind of curious. I've never used one of those for a vasectomy. I think that's really handy. I think they're a little more pricey. As they said in that talk, the alcohol is a good idea because it does help to boost the chlorhexidine effectiveness for preventing infection. There was actually a list of antisepsis techniques that they recommended for different procedures. And the big thing about it is the things with CHG in them have a much longer duration of effect. Now, vasectomy is such a short procedure. We use the betadine. I don't know what anybody out there uses. Put it in the comments if you'd like, and we'll share that. But betadine, as you can see from the top, says it gives a 2-hour worth of disinfection, and that's more than plenty. If it takes somebody more than 2 hours to do a vasectomy, you better find a new doc. But the other ones are nice, and I think that one of the things with the CHG and any of these things that have alcohol is to keep in mind that most of the docs that are doing vasectomies are using electrocautery, and electrocautery is a spark, which you got to make sure that alcohol dried, because that's a good point. It is a fire risk. So that's a good point to have made. And with that, I'm going to pull myself up here to full screen because that's the only slides I had. So any thoughts come up, I'll watch the comments section, but I thought that was kind of neat. Now, if you want to get your contact hour, it's good for a half hour worth of contacts. Just go to the website. Shortly after I end this, I will bring up the updated website that'll have the link that you click. It'll bring you over to that site. Yes, answer a few questions. We're doing this in cooperation with the mycme.com company, who I think you've noticed I've had a relationship. They said, hey, we're glad to have you guys get more people out there, because get their education to more people. And I think it's kind of neat for those of us that need contact hours. It's fun to be able to get some of those taken care of this way, instead of having to go to maybe a formal conference or read stuff online. Things that are, I think, a little certainly not as interesting as me, right? You're a nurse. All right. So I don't see any other comments coming in. I'll give you a few seconds if you do. But we're going to go on to our advertisement for next week's program. I think you're going to really like it. I think some of you should have seen in the last email that came out, there was a survey I put in. Something new that I've been doing for some of these episodes is asking you, the audience, what your practices are, what your thoughts are. So I think it helps to build up the episode. And this idea I got from my most recent SUNA meeting. And I went to this talk, and I'm thinking, here's something that we do every day, day in and day out. And I never really looked at what science there is behind it and how it should be done. But anyway, let's play the roller, and I'll talk a little bit.
Voiding trials are a critical component in determining whether a patient can effectively empty their bladder after surgery or catheterization. These trials involve removing the catheter and assessing the patient's ability to void naturally while monitoring post-void residual urine volume. Traditionally, there are two main methods: spontaneous and bladder-filled assisted trials. After the recent SUNA conference, EuroNurse launched a survey to gather more insights on the best practice model. Our findings, along with the research presented at the conference, highlight the pros and cons of both methods. Join us next week as we discuss these insights and survey results in our next episode.
No, getting in tune with the music. I kind of like that music there. So yeah, next week we're going to talk about voiding trials. And Diane Newman was the presenter. And if you don't know Diane Newman, Dr. Diane Newman, I mean, she is, as I told her after her presentation, I said, only you could make this so interesting. But she really is fantastic at what she does. She puts the re in research and the E in evidence. I mean, she is one that looks at the facts to support whatever she has to say. And she had some interesting things to say. So I did tell her I was going to rip her off and have an episode on it, because I thought it was something that was definitely worth looking at next week. So we're going to look at trials of voids. So again, I did put out that research. I think all those that have already answered the little survey, it's short, and it does give me some food for thought. And here's a bonus for next week. And I'll be presenting, by the way. So the bonus is my expert panel is going to consist with Diane Newman. So I'm bringing Diane Newman on to be one of our experts for the afterward Q&A. So this is your chance to really, kind of, besides talking to me every week, get a real in touch with a real expert on it. So I'm looking forward to that myself, because I think Diane is fantastic. So join us next week for that. And I'm just going to take a quick peek at the comments just to see that I didn't miss anything. Alrighty, here we go. Glenda said, excellent program. Thank you, Glenda. And Tabo, looking forward to next week's topic. Good. I hope everybody is. I think it's going to be fun. With that, I don't mind leaving a little bit early because I got work to do. So the rest of you enjoy I don't know what your weather is out by you, but I'm in the Chicagoland area. I think, I live in just south of it in Northwest Indiana, but our weather is beautiful. We have the nights going down and only into the 50s, and the daytime temperature up in the high 70s, mid 70s. I actually was going to take my boat out today, but I think I'm going to leave it in for another week. It's supposed to be beautiful all week. Get a few last minute trips out on the boat. So it's really great. I hope you're enjoying this beautiful weather, and we'll see everybody next week on euronurse.com.